Welcome to Pan-Viral Actions, a call to implement one-stop screening. I'm Dr. Stacey Trooskin, Executive Medical Officer at Mazzoni Center in Philadelphia, Pennsylvania. Today, we'll be discussing the role of substance use disorder centers in triple screening for HIV, hepatitis C, and hepatitis B. These are our disclosures. Today's learning objectives are to define current screening guidelines for HIV, hepatitis C, and hepatitis B, including for people at highest risk. We'll identify optimal community and clinic-specific strategies to efficiently conduct pan-viral screening for HIV, hepatitis C, and HBV, and we'll establish linkage to care pathways for patients who require follow-up for all three viruses, either treatment or prevention. Let's start off with discussing the epidemiology and burden of HIV, hepatitis C, and hepatitis B. When discussing hepatitis C epidemiology, we're really talking about how there are two epidemics that are closely intertwined, otherwise known as a syndemic. What we have is the critical convergence of hepatitis C virus and opioid use disorder. 23 to 39% of new cases of hepatitis C are in people who inject drugs, and 52% of people with acute hepatitis C infection in 2022 reported injection drug use. And we largely would assume that that's an underestimate because a lot of people are not either comfortable or willing to share their injection drug use history. We know about 40% of individuals with chronic hepatitis C are unaware of their status, and getting diagnosed is really the first step towards cure and more global elimination of hepatitis C. There is also a risk of acquiring HIV infection among people who inject drugs. About 7% of new HIV diagnoses in 2022 were attributed to injection drug use. We know that sharing syringes and other injection equipment is also a high-risk behavior for acquiring HIV. Receptive anal sex is actually the number one risk factor, and sharing contaminated injection equipment is the second highest risk factor. Substance use disorder may increase the risk of getting HIV through sex as well. People under the influence of drugs and other substances are more likely to engage in higher risk behaviors for acquiring HIV, such as engaging in sex without a condom, sex with multiple partners, or sex in exchange for money, drugs, or even housing. People who inject drugs also have an increased risk of hepatitis B infection. Injection drug use is the most common risk factor for acute hepatitis B infection, and 23% of people who inject drugs have evidence of at least past infection of hepatitis B. Up to 20% of people who inject drugs do have chronic hepatitis B virus, compared with up to 0.7% of the general population. So the community of people who inject drugs is disproportionately impacted. And unfortunately, only 30% of the adult U.S. population has been vaccinated against hepatitis B. And vaccination rates are often lower among people who inject drugs. And we know that vaccination can prevent infection. So it's critical that we begin to expand vaccination among all Americans, and particularly people who are at risk for acquiring hepatitis B infection through injection drug use. Having hepatitis C, hepatitis B, or HIV also increases the risk of contracting one of the other conditions or worsening existing hepatitis B virus or hepatitis C infection and the long-term sequelae associated with those infections. Let's turn our attention to screening guidelines. According to the CDC, and the HIV testing guidelines, I'd like to review for you who should we be testing and how should we be testing them. So let's start with who. The CDC says that all adults and teens aged 13 to 64 years should be tested at least once in routine healthcare. We should be also testing all pregnant people. And there's a group of individuals who should be tested at least once a year. Some of these individuals could be tested up to every 3 months, depending on their overall risk and exposures. So among this group that should be tested more frequently, individuals who identify as men who have sex with men, or anyone who also is trans-identified, people who inject drugs who also share injection equipment. That's a critical piece of this. Anyone who engages in sex for drugs, housing, or money, individuals who are incarcerated, individuals with a current sexually transmitted infection, hepatitis infection, or tuberculosis, and anyone that has a partner who has HIV infection or more than one partner since the individual's last HIV test, and really also anyone having sex without condoms. Let's talk a little bit about the how. How do we test for HIV? Well, this should be routine opt-out testing. What does that mean? So opt-out screening is when you offer tests just as part of routine healthcare. Think about when we screen somebody for high cholesterol or diabetes. This is just part of the normal panel of tests that we order for most American adults. The same should be true for HIV testing. If someone comes in for a routine visit or to establish care in a setting, we would say, hey, today we're going to do some routine tests for you. Someone can always say, listen, I don't want my blood drawn today. That's opting out. The difference there is that this is just offered as a standard practice. Opt-in screening, which we do not endorse, is, hey, would you like to be tested for HIV? And then that individual opts in. We don't want to do that. Opt-out screening is the way to go, just part of routine care. And that allows us to normalize testing. HIV screening is a CDC-based recommendation. We do that the same way that we provide other routine health screenings that don't have the same stigma attached to them as that HIV does. The CDC also recommends initial testing with an FDA-approved antigen antibody assay. There are no oral tests that we offer as part of that routine screening. Fourth-generation HIV test does include both that antigen and antibody results, and a patient can determine whether they have HIV in as little as 2 weeks after exposure. And it really is that ability to catch that new infection, which is why that fourth-gen test is recommended. Who should be tested for hepatitis C? In 2020, the CDC expanded their recommendations to include universal HCV screening. So that means hepatitis C screening should happen at least once in a lifetime for all adults aged 18 or older. Hepatitis C screening should happen for all pregnant people during each pregnancy. One-time hepatitis C testing, regardless of age or setting prevalence among persons with recognized conditions or exposure, include people with HIV, people who ever injected drugs and share needles, syringes, or other drug preparation equipment, including those who injected once or a few times many years ago, and then children born to gestational parents with hepatitis C infection. And so this testing can occur in individuals, notably, that could be younger than 18 years of age if they fall into this risk category. The CDC also recommends routine periodic testing for people with ongoing risk factors while those risk factors persist. So people who are injecting drugs and share needles or other injection preparation equipment should be tested routinely. I would say at least annually, but more frequently as needed or indicated. People with select medical conditions, including people who have ever received maintenance hemodialysis, also fall into that category. And then anyone who requests hepatitis C testing should receive it, regardless of their disclosure of risk, because many people may be reluctant to disclose these stigmatizing risks. Who does the CDC feel should be tested for hepatitis B? Well, their 2023 recommendations are as followed. One-time hepatitis B testing is recommended now in a universal way. We should be screening all Americans at least once in a lifetime if they're 18 or older using a triple panel test. This includes surface antigen, surface antibody, and core antibody. Hepatitis B virus screening for infants born to surface antigen positive people should also occur, both for antigen and anti-surface antibody serum markers. Hepatitis B screening for all pregnant people should also occur during each pregnancy. There should also be routine periodic testing for people with ongoing risk factors while those risk factors persist, including people who inject drugs or those who have a history of injection drug use or who have shared needles or engaged in any sexual contact with people with known hepatitis B virus infection. Individuals with a history of STIs or multiple sex partners, either a history of past or current hepatitis C infection or with HIV infection, should also have routine periodic screening. incarcerated or individuals who are formerly incarcerated should also be screened. And then individuals born in regions with hepatitis B virus infection prevalence of greater than or equal to 2%, or unvaccinated people whose parents were born in those geographic regions with a surface antigen prevalence of greater than 8%. Anyone who identifies as a man who has sex with men, and folks that have household contacts or former household contacts of people with a known hepatitis B virus infection. And then, of course, anyone who's on maintenance dialysis or people with elevated liver enzymes of unknown origin. And then lastly, similar to hepatitis C, anyone that requests hepatitis B virus testing should receive it, regardless of whether or not they disclose a risk factor. So now that we know how and who we should be screening for these 3 viruses, how can we implement and conduct pan-viral testing? Let's talk about options for point-of-care testing for use in substance use disorder centers. For HIV, there are multiple tests that are available. However, most only detect HIV antibody, which requires a certain amount of time from infection to develop antibodies. So you're not really getting those new infections. There right now is only one approved rapid point-of-care test that detects both antibody and antigen. Many finger test options exist, and although not recommended, there are oral tests that are available. And results can be populated within a few minutes, which is really great for environments where you see kind of high turnover or a transient population coming in for services. For hepatitis C virus, most test only for hepatitis C antibody, which only shows if a patient has ever been infected with hepatitis C virus. We know that 15 to 25% of people that are exposed to hepatitis C and infected are able to clear the virus on their own. So looking for that RNA is a critical piece to making the diagnosis. There is right now one point-of-care HCV RNA test that has come to market. There are finger-sticked options that are available, which is helpful for people who inject drugs and may have compromised venous access. Dried blood spot testing is available, although that's often a send-out test and takes a couple days to get back. But the rest of the point-of-care tests can have results available in a few minutes. It's important to recognize that there are next steps for positive antibody tests, which requires blood being sent out for confirmatory testing. Note that there are no point-of-care tests available for hepatitis B virus at this time. It's not uncommon for me to get questions from substance use disorder treatment sites that have not even yet embarked on any sort of pan-viral testing or even one viral testing. And so for sites that are interested in just starting with point-of-care tests, they may be wondering how their staff might get trained. And for that, I would encourage you to reach out to your Department of Health to understand what requirements are there regionally around training for people who are doing point-of-care testing and utilizing CLIA-waived tests within your site. So there will be certain rules that you'll need to follow and certain training that your staff should have to make sure that they're comfortable and competent in performing those tests, to make sure that you're running your controls so that your tests are valid. That's a fundamental step that most sites should be taking before you implement point-of-care testing in a routine opt-out way. When we use a 4th-generation HIV test, there are a couple of steps intrinsic to what the lab will do after that blood is drawn. 4th-generation HIV tests that detect both antigen and antibody are the recommended form of testing by the CDC. 4th-generation tests can be positive as early as 2 to 3 weeks after exposure, whereas 3rd-generation tests detect only antibodies, which appear after the antigens have been present. And positive HIV tests almost always must be reported to the health department. So when you perform an HIV 1 or 2 antigen antibody immunoassay, the first step is to determine whether or not it is reactive, okay? If it's non-reactive and the person is HIV negative, if there's acute infection that's suspected, you have to perform a NAT test. For step 2, We perform HIV 1 and 2 antibody differentiation. Most labs will perform this as a reflex test if the initial test is reactive. And reflex testing means it's all done with the same tube of blood. You don't need to call the patient back. If HIV 1 or HIV 2 has antibody detected, then you want to initiate antiretroviral therapy rapidly. Same-day starts are the standard of care. If there's no antibody detected for HIV or it's indeterminate, then we go on and perform that HIV 1 NAT test. And again, most labs will perform this as a reflex test if the differentiation is positive. If HIV RNA is not detected, the patient is negative for acute HIV-1 infection. If there is RNA detected, then we know there's acute infection and we initiate antiretroviral therapy. For hepatitis C testing, it's also a two-step test. That doesn't mean we need to draw blood on two separate occasions, though. If we draw blood and we do reflexive testing, the lab will first assess for that antibody. Antibody tells us whether or not they've been exposed to hepatitis C. If the antibody is not reactive, there's no hepatitis C antibody detected, and we can stop with one caveat. If somebody has had a recent exposure to hepatitis C, let's say they injected drugs in the last 2 or 3 days, that antibody won't be present. Then what you need to do to assess for acute infection is do an HCV RNA test. If that antibody test is in fact reactive, that means that we need to either reflex to an HCV RNA test, or if you're using a point-of-care test, you need to then send the patient for phlebotomy so they can get an RNA level checked. If there's no RNA detected, it means there's no current HCV infection, unless, of course, they're still very much in the acute phase window, in which case you want to bring that individual back in a few weeks to be retested. If there is RNA detected, that means they're infected, and you link that person to care and to cure. The CDC recommends this two-step testing sequence, and samples should be collected at that single visit for reflexive testing. Hepatitis C is also a notifiable disease, and positive tests must be reported to the health department. In terms of testing for hepatitis B, unfortunately, there is no rapid point-of-care test available in the U.S. for hepatitis B virus. It is, however, possible to obtain a blood sample on site for a dried blood spot test, but it still has to be sent out to the lab, as would any confirmatory HIV or hepatitis C test. For laboratory-based screening for hepatitis B, we do recommend a triple screen. As mentioned before, that's a surface antigen, the presence of which indicates a current hepatitis B infection, a surface antibody, otherwise known as anti-hepatitis B surface antibody, appearance, which occurs after a decline of the surface antigen, and it indicates often recovery or the development of that antibody. We also check total anti-core antibody. This develops in all hepatitis B infections and doesn't help us determine whether it's a resolved infection or current, but it often does not occur from vaccination. Some blood samples that are used for confirmatory HIV and hepatitis C testing can also be used for hepatitis B tests. So you can use the same blood sample for confirmatory HIV testing and hepatitis C testing that you use for hepatitis B. Panviral testing is pretty simple when you have on-site phlebotomy and you're not forced to use a point-of-care test. Methadone clinics with phlebotomists can draw blood. It's helpful if these 3 tests are bundled together and are associated with higher rates of completion. The intake process can also often be modified to include panviral screening in addition to any other lab work that the intake process requires. And it's helpful to connect with county health departments for reporting positive test results and to develop a smooth protocol with them. If you do not have phlebotomy access on site, rapid point-of-care tests that test only for HIV or hepatitis C antibodies or oral HIV rapid tests do require confirmatory testing with phlebotomy. So establishing these referrals is a critical piece of this. Remembering that hepatitis B testing requires blood to be sent to the lab always. So the way to establish these referrals are partnering with community-based health centers, health departments, anywhere where patients can go for same-day confirmatory blood draw. It's important to recognize that individuals may have a copay associated with their blood draw. The cost that they will experience is often dictated by their payer. It's often difficult for patients to move from one place to another, and to have a process that supports patients when referring them out is critical. So whether that's a navigator, whether it's supporting transportation, whether it's giving them explicit directions and how to get there, or making an appointment on their behalf, all of those things are options to support a successful referral. It's also important for us to make sure there's good communication between the site and the referring partner. For sites that may be using some of those CLIA-waived tests and doing point-of-care testing, they may be wondering, how could I get started with doing some of these confirmatory tests or phlebotomy tests already on site? And if you have staff that you think would be a good fit for starting to draw blood, and you want to give them that professional development and the opportunity to learn a new skill, there are certainly certificate and other training programs that are available that staff can be sent to obtain phlebotomy certification. Ordering the appropriate supplies can be done through medical supply companies that you may already have a contract with, but making sure that you have the appropriate tubes on site, butterfly needles, tourniquets, alcohol swabs to support your staff and in providing the appropriate phlebotomy, as well as drawing that pan-viral screen is an important consideration when implementing phlebotomy on site as well. Whether you're doing it to do the reflexive test or you just want it available for confirmatory testing, you want to make sure you have everything you need to make it successful and to support your staff in an easeful implementation. Utilizing your EMR in adopting pan-viral screening is really helpful. So EMRs are a powerful tool in adopting pan-viral screening. So if you have an EMR, they can be used to identify if and when a patient has already been tested for HIV, hepatitis C, or hepatitis B, and you'll know what those test results are. It also helps substance use disorder treatment programs to identify locations or opportunities in their workflow where patients can have the blood drawn for routine opt-out screening. And then there are ways that you can incorporate pop-up reminders, leveraging the quality functionality around quality outcomes and measurements in the electronic medical record. You can also use different note templates, order sets, all to help facilitate testing. There are, of course, barriers to utilizing EMRs. The largest barriers to EMR adoption include the cost of startup, ongoing maintenance cost, but EMRs can really help streamline workflow as well as overall clinic productivity. But all substance use disorder center staff should be trained in how to utilize EMR tools if they're going to be part of this process. The utility of opt-out screening at substance use disorder treatment centers is critical. Opt-out approach for testing is recommended by the CDC. The idea here, again, is that we inform patients that testing is going to be part of their routine care, and this does help reduce stigma associated with testing. Opt-out viral testing has been shown to increase testing rates, as well as rates of linkage to care. And this opt-out pan-viral testing could occur at any point. It can occur during intake while the patient is waiting for a dose of their MOUD, after a group session. It just needs to be worked into the workflow in a routine way so that it applies to all patients and is smoothly integrated into the process. So how can you determine where opt-out testing best fits into your established intake protocol? Every site is different. Every site brings patients into their facility in a slightly different way. So it's up to you to take a look at your staffing model, to take a look at where you provide certain medical interventions, whether that's a required EKG before somebody initiates methadone, where it's a comprehensive metabolic panel, Wherever you're already providing some of those medical services within your substance use disorder treatment program is where you can insert your pan-viral testing. And if you happen to be a site that is not providing medication for opioid use disorder or any medical services, thinking about where you can incorporate that point of care screening in your intake process is a critical piece of this puzzle. So what can a proposed workflow for triple testing look like? Well, the first is to talk with your team. You want to figure out who are going to be the folks that support the integration of this process. You want to develop and agree upon what those testing protocols are, whether you're using phlebotomy or you're using point of care testing. Every site needs a testing champion, someone who believes in this and is going to want to lead the charge in making it happen and then troubleshooting it when implementation maybe doesn't go quite as planned. It's helpful if you have an electronic medical record to create a clinic reminder and include documentation within the template that you're using. Then again, you roll out and you can start performing your opt-out testing at an agreed upon point in the intake process. If it is an on-site blood draw, you want to make sure that you're delivering test results to your patients or clients as soon as they're available. And if it's an off-site blood draw, then you want to coordinate with that facility where the blood was drawn to make sure that you have open communication and all of the paperwork in place to share that critical clinical information, whether it's a BAA or something else. You want to make sure that you're still abiding by the rules of HIPAA and working to support your patients collectively with good collaboration. And then once you have a diagnosis, you want to refer your patient for treatment or prevention services as necessary. Addressing insurance coverage obviously is important when it comes to both testing and treatment. In the United States, we have a pretty siloed payer system. We have physical health payers, which cover most of our medical care that is often provided in physical health type settings. And then we have behavioral health payers, which provide often the coverage for substance use disorder treatment. Figuring out where there's overlap between physical health coverage and behavioral health coverage is important. So in terms of the behavioral health payers that a substance use disorder treatment site most commonly sees, you want to figure out what testing is covered. And if there's no pan-viral testing covered, that's an opportunity to talk with that payer leadership to make sure that they understand that identifying HIV, hepatitis C, and hepatitis B infection is a critical piece of providing substance use disorder treatment. But making sure that your patients have coverage that they're entitled to is the first step, okay? If you are unable to provide testing that's reimbursed at your site, thinking creatively about how you might be able to partner with physical health providers. Perhaps it's providers from a federally qualified health center, or maybe even if the Department of Health runs clinics in your jurisdiction, you want to have them come on. Maybe it's partnering with academic medical centers and ensuring that you can work together so that you're providing some modicum of physical health care, which includes pan-viral screening and perhaps even treatment embedded within your substance use disorder treatment site. There are also advocacy organizations that help provide support for obtaining insurance coverage for your patients as well, if that's something that you don't have the bandwidth to be supporting among your patient population. Substance use disorder centers that have implemented HIV and hepatitis C testing protocols have seen extraordinary outcomes. And so the key approaches to improving testing and treatment include ensure that testing is part of all intake, having an automated process or a checklist for ordering the appropriate tests, allowing for these bundled orders for intake testing, and then ensuring that you're communicating the test results back to the patients and facilitating linkage to care or even on-site treatment is best. And then making sure that you're counseling those patients who are negative to maintain their negative status. And you can see on this graph here that after protocol changes have been implemented, there are tremendous increases in rates of testing, engagement in care for HIV, as well as hepatitis C. It's critical to establish treatment pathways once a diagnosis has been made. The first step of a successful treatment pathway is making sure your patients are educated. You want them to understand, most importantly, that life expectancy is nearly equal between people living with and without HIV. That people that are diagnosed with HIV today have longer life expectancies versus those that were diagnosed many years ago. The critical phrase here is that HIV is not a death sentence. This is a chronic infection that can be managed over time. Individuals are more likely to die of non-HIV-related illnesses than of HIV. And so I often will say to my patients, HIV is something that you die with, not from anymore. Educational strategies include asking open-ended questions about what your patient knows about HIV, considering putting a patient in touch with other adults that are living with HIV to hear about their experiences. If you have access to resources that include support groups, it's critical to be able to connect individuals to those types of services. Providing educational materials at the appropriate literacy level is also important. Viral suppression is key. Initiating antiretroviral therapy as soon as patients are diagnosed helps them become virally suppressed more quickly and makes it very difficult to transmit HIV to sexual partners or injection partners when they're virally suppressed. There's a concept of U equals U, undetectable equals untransmissible. So the rapid start is now the standard of care as it relates to HIV diagnosis and treatment. As a substance use disorder service provider, what should you be telling patients about hepatitis C treatment? If you remember nothing else, it is that hepatitis C is curable with treatment. Treatment is both feasible and highly effective. Cure will eliminate the virus in more than 96% of the people that take the medication as prescribed. Treatment is feasible and effective for people on medication for opioid use disorder, as well as those who continue to engage in injection drug use. Treatment may be as simple as 1 to 3 pills once a day, and it's brief, only 8 to 12 weeks with minimal side effects. These medications are very well tolerated. It is also important to remind our patients that they need to complete the entire treatment course and then follow up 12 weeks after they take their last pill in order for us to establish that cure has actually occurred. There are lots of things that you can tell your patients about cure. Cure is defined as the absence of virus in the blood 12 weeks after treatment. And cure not only benefits you as a patient, but the entire community by decreasing transmission of the infection, because you can't give away something that you yourself do not have. So transmission is interrupted with cure. It's also important for us to talk to our patients about the possibility of reinfection. Hepatitis C antibody is not protective, meaning that individuals who continue to inject drugs and are sharing equipment or contaminated equipment may get reinfected. Those individuals who are reinfected should be retreated, but we want to try to prevent that from happening in the first place. So access to clean syringes and equipment is critical, and you want to make sure that your patients know what they need to do to keep themselves safe and reinfection free. But the risk of reinfection should not defer or deter somebody from being treated. Hepatitis C antibody will remain positive indefinitely, so also making sure that your patients know that even if you're cured, your antibody will remain. The important test that they'll need is an RNA test moving forward to make sure that they're not reinfected. Hepatitis B treatment is a little bit more complicated, although there have been attempts to simplify this, particularly with the World Health Organization's 2024 updated guidelines. Right now, there is no treatment available necessarily for acute hepatitis B infection. There are multiple oral treatment options for chronic hepatitis B, however, and it does require prolonged or even lifelong treatment. World Health Organization's 2024 updates have reduced the restrictions requiring hepatitis B virus DNA testing for treatment, allowing more people to easily access treatment. And it's critical that you refer any patient with a positive test to be evaluated for treatment by somebody who has the skills to do that. Delivering test results is not as scary as some people might think it is. It's an important piece and a responsibility when you're providing testing services at your site. The first thing you want to do is make sure that you're with the patient in a private, comfortable space. You also want to use some of those educational points that I just reviewed with you to provide some reassurance and remind patients of the facts of what may be their forthcoming diagnosis. For example, before you deliver a diagnosis of hepatitis C infection, it's important to review, I just want to make sure you understand that this is a curable infection. Or with HIV, reminding individuals that HIV is not a death sentence, that this is a treatable chronic infection that can be managed, and people have long life expectancies with it. I find that providing education up front is important because once you deliver the actual diagnosis, individuals stop listening and they start to get in their own heads about what this means for them. When you actually get into delivering the test result, if it's a rapid test, you want to calmly explain that the rapid test is positive and a confirmatory test is needed. And if you're delivering a confirmatory test, you want to explain that it means the patient has the infection. Again, reiterate that medications are available and that these things are treatable. And if the test is negative, you want to engage the patient in a conversation to discuss prevention techniques. There are a lot of other training modules or scripts that can be used to support your learning about delivering test results. So again, specific examples of language you can use when informing a patient of a positive test result includes reminding individuals that hepatitis C is curable, hepatitis B is treatable, HIV is not a death sentence. HIV is something that can be managed like other chronic illnesses. So providing reassurance to individuals is critical. It will help take the temperature down a little bit, and then you can be set up to then link that person to the care that they deserve. So when you're linking folks to care, who do you refer? You want to refer any patient who requires treatment, and you can refer to a myriad of sites. You want to know what the resources are in your area, places that are geographically convenient for the population that you serve, that have a low barrier opportunity to engage in care. Some of those sites may include federally qualified health centers or other community health clinics, Ryan White-funded centers for HIV care, other local hospital systems with infectious disease expertise, or perhaps even gastroenterology or hepatology if you're dealing with a viral hepatitis diagnosis. It helps if you have clear workflows for referral in partnership with these organizations so you can really work to support the patient for a smooth transition. There's a big difference between calling on behalf of a patient and setting up an appointment or giving that site that you're referring to a heads up that a patient is going to be coming, rather than just handing a patient a slip and saying, here are a couple places you could go to get treated. That warm handoff really helps make a difference. Prevention is critical also. When we're talking about preventing pan-viral infections, there are tools that we have for each one. HIV prevention is not just for men who have sex with men or people who are engaging in higher risk sex. It's also for people with substance use disorder. So we can be using PrEP or pre-exposure prophylaxis. It's a comprehensive set of services that are used to reduce the risk of HIV infection. There are 3 FDA-approved medications for PrEP. These medications can only be used in this combination in people without HIV. We often use some of these medications with other medicines to treat people with HIV, but these medicines can only be used this way in individuals without HIV. So comprehensive services include regular HIV screening, because if someone goes from HIV negative to HIV positive, you have to shift your approach and add some additional medications or switch the meds around. You also want to include regular STI screening. So 3-site screening for chlamydia and gonorrhea should be offered. That's often urine, oral, and anal screening, as well as syphilis testing. We want to provide safer sex and risk reduction counseling. Condoms should be readily made available for folks. And it is so important and the standard of care to be testing for hepatitis B prior to initiating pre-exposure prophylaxis. And the reason for that is that the medication that is used, or some of the medication that's used for PrEP, can also be used to treat hepatitis B. And if you decide to start and stop somebody off of PrEP for any given reason, to do that without the knowledge of their hepatitis B status can cause significant issues down the road. If somebody has hepatitis B and you add a medication, it can suppress their virus, which is good. But if you remove it without knowing that they had hepatitis B virus infection before, their hepatitis B virus can flare and cause someone to really get into trouble with their liver. And you want to avoid that. So making sure you test for hepatitis B prior to initiating PrEP is an important step of providing comprehensive prevention for HIV care. So here are the 3 medications that we use for HIV prevention or PrEP. One is TDF-FTC. It's marketed as a drug called Truvada. It's pretty simple, 1 pill once a day. It's approved for any adolescent or adult that is at risk for acquiring HIV, including people who inject drugs. TDF may increase the risk of renal disease and low bone mineral density, and it is available now as a generic. TAF-FTC, which is marketed as Descovy, is 1 pill once a day, and it's also approved for individuals at risk of sexual acquisition of HIV, excluding individuals at risk from receptive vaginal sex. And the last option here is cabotegravir, which is marketed as Apretude. It's 1 IM injection every 2 months after loading doses, which are given monthly. It's approved for use in anyone at risk for acquiring HIV through sex, and these individuals have to come into the clinic to receive the injection. So it's very convenient in that it's not a pill that you have to take at regular intervals, but you do have to come in to the clinic at a particular window of time in order to remain protected. So people who inject drugs are in fact prime candidates for PrEP. And we want to make sure that we're lifting that up to them as an option for prevention. Key messages for patients to know about PrEP. PrEP is only for people who do not have HIV infection. It's for everyone, not just men who have sex with men. PrEP can reduce the chance of getting HIV through sex by about 99% and from injection drug use by at least 74%. But PrEP must be taken regularly and as prescribed to be effective. Patients will need to have a blood test before they can start PrEP, and then will need to be tested for HIV every 2 to 3 months while taking PrEP. There's also the opportunity to prevent HIV with something called NPEP. NPEP is non-occupational post-exposure prophylaxis, which is really the use of antiviral medication after a very recent potential exposure to HIV to prevent infection. It's important to know that medication must be started within 72 hours of a possible exposure, so time is of the essence. We test individuals for HIV prior to initiating NPEP, and patients have to follow up with the prescribing clinician at 72 hours after exposure to make sure they receive the meds. We check in around side effects, etc. A medication is taken every day for 28 days, and then we discuss a transition to PrEP. We also have to continue HIV and STI testing, and for the most part, this is covered by insurance. And if it's not, by some chance, there are usually patient assistance programs that can be made available on an urgent basis. When we think about prevention, there's an amazing tool that we have for hepatitis B, and that's called vaccine. We recommend this for all children, adolescents, and adults up to age 59. It's also recommended for those greater than or equal to 60 years who have risk factors for hepatitis B infection. Depending on the brand of vaccine that you use, and there are a couple of options, it's either given as a series of 2 or 3 shots. If it's 2 doses, you space it a month apart. If it's 3 doses, those 3 are given over a 6-month period. And there's also something called a birth dose, which is a dose that should be given to all infants at birth. And it's important to know that hepatitis B vaccination is in fact safe for pregnant people. Vaccines are available at pharmacies, provider offices, community health centers, and also health departments. So you want to check your local region to figure out where you can instruct patients to go to receive their vaccine if they're not yet immune. So in conclusion, there is a significant risk of HIV, hepatitis B, and hepatitis C among people who inject drugs. There are lots of options for on-site testing that are available for both HIV and hepatitis C. And these include point-of-care tests where test results can be available within moments of the test occurring. Hepatitis B virus testing has to be done in a lab, but blood can be drawn on-site in a substance use disorder center if you have phlebotomy and trained folks available to do that work and then process the blood for pickup. Opt-out triple screening is feasible, remembering that opt-out screening is simply incorporating that pan-viral testing into your routine workflows. Figuring out where in your workflow this screening can occur will depend on each individual site. But if you are already providing some medical intervention, whether it's an EKG, a blood draw of some kind, or some other kind of health screening, that could be a good opportunity to implement some of that triple screening in an opt-out way. EMRs can be useful in tracking screening and results. So remembering that if you have an electronic medical record utilizing pop-ups, reminders, if you have quality tabs or quality tools that are available through your EMR, leveraging those as a reminder that this person has not yet received their triple screening, utilizing order sets so that individuals can just pull in all of the appropriate tests all at once into their order or their progress note, or even having templated progress notes that are pre-populated with those order sets can be a useful tool that you can implement. Substance use disorder centers should be prepared to perform initial patient education about a positive test, whether it's the first test before you get referred out for the confirmatory test, or whether it's about disease prevention. And so if somebody has a negative test result, you want your staff to be prepared to talk to individuals about prevention and ways to stay negative. And then for those individuals that are in fact positive, you want to make sure that you have nice, smooth referral pathways that support a successful linkage to care process for your patients for both HIV, hepatitis C, or hepatitis B treatment. You also want to make sure you have a nice referral pathway available for HIV prevention, as well as hepatitis B vaccine. And again, knowing those resources that are available to you among your community is going to be a way to really make that process as smooth as possible. Thank you for joining us for this program. Please remember to take the post-test and fill out the CME evaluation. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com.